All right, Smita, if you want to share the intro slide. Good afternoon, everyone. Yeah, I guess it's afternoon. I hope everyone is doing well and keeping warm or dry. I know in Toronto, this big snow we had, it's all melting and it's really kind of ugly outside now, melting and brown snow. Smita, are you able to share the slides?
Yeah,
So everyone, we've had a few little tech glitches this morning already, but we should be starting soon. I know there's still some people trickling in, I see, so we'll get started shortly.
yeah, I'm trying to, but I don't know why it does not show on my end the option to.
Share your.
Yeah. Okay.
Oh, there we go.
Okay. Sorry.
Just put it in presenter mode. Can.
Yeah.
Perfect. All right. Again, good afternoon, everyone, and thank you for joining us for our first Pediatric Diabetes Network webinar of 2025. I'm really excited for our presentation today. Before I hand it over to our speakers, I would just like to do a land acknowledgement and some housekeeping. And then, like I said, I'll hand it over to our presenters. Advance the slide. Thanks, Mita. I would like to begin by acknowledging my sincere gratitude for the opportunity to work on this beautiful land, live and work on this beautiful land that has been occupied by First Nations since the beginning of time. This land on which PCMCH operates is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe peoples. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13, with the Mississaugas of the Credit. Toronto is now home to Indigenous peoples from across Turtle Island. PCMCH recognizes that Indigenous practices of health and well-being have been in place in this territory since the beginning of time and are maintained to this day. We are committed to honoring and improving our knowledge on these practices. We recognize the harms and mistakes of the past, and we take meaningful steps toward reconciliation by building and improving relationships with First Nations, Inuit, and Métis peoples. And I think this is not news to many people here. We know the importance of respecting and acknowledging Indigenous approaches to health and wellness in the diabetes space, particularly given the high prevalence of diabetes among Indigenous populations. Next slide, please. So before handing it over to our presenters, I just want to remind everyone about the functions of Zoom. So everyone is automatically muted, but if you have a question after the presentation, use the raise hand function and we'll give you permission to unmute, or you can ask questions using the Q&A function. We'll aim to have some time at the end for Q&A. Next. And I will pass it over to our presenters. And I just want to acknowledge that as advertised, you might see some different names and faces than who was initially advertised to present. But unfortunately, Anne-Sophie is sick today, but Amelie kindly jumped in to take her place this morning. So big thanks to her. And I look forward to the presentation today. So I'll hand it over to our presenters to share their slide and share their really interesting work with you all.
Thank you, Leslie. It's a pleasure to be here. I'll start by sharing my slide. How's this? Works okay? Okay. So thank you everyone for being here, and thank you for the invitation. My name is Amélie Roy-Fleming. I'm a research coordinator in Dr. Brazo's lab. I've been working with her since the beginning of the Better Project, which is a big part of our research program, which we'll tell you about. And I'm joined by Asma Usni, which is a PhD candidate in our lab. which is towards the end of her her diploma, and so she's mastering more and more the different research we're doing in our lab, and so we'll be working together on this presentation. Today we'll present part of our research program, which takes a big importance in integrating the input of people living with type 1 diabetes in order to address their needs specifically. And more precisely, we'll be talking of how we address stigma in our research, as well as insulin omission for weight loss, and a bit more on online diabetes self-management education, which we do a lot of research on as well. We have no, asthma and I don't have conflicts of interest to declare.
All right, so we're going to begin the presentation by asking you the following question. Anxiety appears in 20% of the patients with type 1 or 2 diabetes. Do you think this statement is true or false? And we're going to leave you a moment to record your answer. Okay, so I see that the majority said true. And so let's see the answer. So it's actually much higher than that, and it's over 40% of patients with type 1 or type 2 diabetes that report having anxiety. And this is not surprising statistics because living with diabetes isn't just about managing blood glucose. It also comes with an emotional and psychological burden, whether it's fear of judgment from others who may not understand the condition and hesitating in managing their diabetes openly, or concerns with body image. Things like weight changes with the introduction of insulin and wearing visible devices like pumps or CGMs can further impact self-esteem. Or identity struggle. Diabetes is a lifelong condition, and integrating it into one's sense of belief or one's sense of self is challenging. So some struggles may feel different, or they wouldn't not necessarily want diabetes to define them, and that can make disclosure or acceptance difficult. Anxiety, the constant need for monitoring, the risk of high or low blood sugar can contribute to anxiety, whether it's worrying about long-term complications or feeling overwhelmed by the daily demands of self-management. And isolation, a lack of understanding from others can make diabetes feel lonely, especially in social settings. And these are just some of the many challenges people with type 1 diabetes may face alongside carb counting and monitoring blood sugar and daily management.
And so to address these different challenges and to learn more about them, we've developed the Better project, with which we hope to bridge the gap to ensure research aligns with the real needs of people with type 1 diabetes. So I think the first most important thing is that since the beginning, we've worked with people with lived experience. So individuals living with type 1 diabetes and parents of children living with type 1 diabetes. So they've helped us orient all the research, and they are implicated in every step of the way. We call the Better project. The Better project has 3 different branches. One of its main branch is a registry for which we have over 4,800 people registered at the moment. So we gather. So it's patient-reported outcomes. We have individuals answering online questionnaires. We have a biobank, which is more recent that we've started, and we have a support online training platform, which responds to the different needs we identify from the registry data. And so we hope that this improves the life of Canadians with type 1 diabetes with our research, and we can tailor the training and resources for them. So as I was saying, we engage patients throughout the different process of the research. We also have a big team of healthcare professionals and researchers, students and decision makers. So we try to have sort of an all-around team that can work together. For instance, at first, the Better Project was really aimed at hypoglycemia and the rapid evolving technologies and treatment for type 1 diabetes. And so the hypoglycemia is a question that was brought by the patient partners that really told us, well, living daily with diabetes, hypoglycemia is our biggest challenge. So this is why we started by addressing this specific question, just to give you a specific example of how their input really shapes our research. So far, so we have many students. So far, we have 18 students that have been working with us and published many manuscripts. If you want to know more about the Better Project, if you don't already, please feel free to visit our website. This is also the link to register for the registry for the patients. So at first, so we have in our like sort of our continuing research process. So the patients help identify the areas of research we should be touching on. So we have monthly meetings. We have a French and an English speaking. So we have 2 different patient partner teams, and through our discussions, we identify questions, research questions that align with the data we are collecting in the registry. And they also, so the patient partners also help us recruit and have a bigger outreach, so they can outreach in their own communities and online as well. They help us interpret the data. We get their input once the analysis are done, and they help us write or review manuscript. And they take a big part in the transferring knowledge. It could be throughout. So we have a lot of news blogs on the Better website. So this is a way they're implicated. And they also, some of them that are more at ease can like give webinars and share their own lived experience.
Right, so as Emily mentioned, one of the components of the Better Project is the Better Registry, which is the first national registry of patient-reported outcomes. We recruited over 4,800 participants living with type 1 diabetes. We recruit mainly through social media, but also in clinics. We developed provincial, national, and international collaborations. And overall, the registry has been a catalyst for accelerating research by providing a large real-world data set, and this has enabled multiple studies to identify trends in patient-reported outcomes, what are the psychological impact of diabetes, health outcomes, and gaps in general in the support systems that are needed to address patients' needs in diabetes care. Data collection is done by a parent if their child is 13 years and under, or by the individual themselves if they're 14 years and older. We have questionnaires at baseline, but we also offer annual questionnaires to gather data over time. Some of the outcomes of interest that we collect are in phase 1, or the first questionnaire is diagnostic history, medical follow-up, complications, the use of technology, the socioeconomic status. In phase 2, or the second questionnaire, we'll look at family history, weight history, smoking habit, medication, hyperglycemia, hypoglycemia. And in the third and final questionnaire at baseline, we look into sleep habits, mood management, stigma, as we'll see today, social support, habits, and barriers of physical activity. And beyond the questionnaires, we also collect, with further consent, CGM data, medication list, blood test, pedometer, waist circumference, and also 24-hour food recalls. So we're going to present 3 patient-informed projects on mental health, each addressing key challenges in type 1 diabetes. First, insulin omission for weight loss and different factors associated with this behavior, type 1 diabetes-related stigma across different age groups, and we'll end with the development of training platforms to support mental health and self-management. So the first study that we'll present today is on factors associated with intentional insulin emission to lose weight in people with type 1 diabetes. And to put the study into context, I want to first introduce disordered eatings. And this figure shows the spectrum of eating behaviors from restriction to disinhibition, with body image playing a key role. And disorders range from anorexia and orthorexia on the restrictive end to binge eating disorders on the disinhibited end, with bulimia and compulsive eating in between. And this highlights how disordered eating exists along a continuum rather than as isolated conditions. So now that we've seen the spectrum of eating behaviors, let's look at what disordered eating can actually look like in daily life. And this can include frequent dieting and anxiety around certain foods or skipping meals. Some may fast or purge to compensate for eating bad food, leading to chronic weight fluctuations. Others develop rigid rituals around food and exercise. There's also an emotional toll, so guilt and shame around eating or feeling a loss of control, especially with compulsive eating habits. And while these behaviors don't always meet the criteria for an eating disorder, they can still have a serious impact on health and well-being. And in the specific context of type 1 diabetes, the risk of developing disordered eating is increased. Managing diabetes places a strong focus on food and requires constant carbohydrate counting, monitoring glycemic impact, and often restricting certain foods. Taking insulin, which is an anabolic hormone that can lead to weight gain, and that can make body weight a concern for many. So with frequent attention to food choices and weight, some individuals may develop rigid eating patterns or anxiety around meals, or even engage in disordered behaviors to manage blood sugar and weight. So this overlap between diabetes management and eating behaviors highlights the importance of addressing this disordered eating in type 1 diabetes population. So we used this question from the Better Registry, and it reads, have you ever intentionally omitted insulin to lose weight? We had 1,186 participants who were included to identify who omits insulin to lose weight. So we looked at demographic factors, mental health, lifestyle factors, and then we also wanted to identify factors that are associated with insulin omission to lose weight. So on average, participants were 44 years of age and 67% self-identified as women. And the prevalence of insulin omission to lose weight was 7.3%, which is relatively low compared to other studies. Of those who reported insulin omission to lose weight, 93% were women. And on average, they had a lower age at diagnosis, and they were more likely to report diabetes-related complications and had a higher HbA1c. And people who reported insulin omission to lose weight had higher scores of depression, had higher scores of diabetes distress, and disclosed more weight cycling occurrences and had a higher BMI. So those who completed a 24-hour recall reported omitting insulin to lose weight had on average higher energy intake, higher fat intake, and higher alcohol intake. When we looked at factors that were associated with insulin omission to lose weight, those who self-identified as a woman had a higher level of diabetes distress and had more weight cycling occurrences, had higher odds of omitting insulin to lose weight. And on the opposite end, being older at diagnosis resulted in lower odds of omitting insulin to lose weight. And there was insufficient evidence for an association between BMI and insulin omission to lose weight. This means that when we consider other factors that are associated with insulin omission to lose weight, like gender, diabetes distress, or age at diagnosis, or weight cycling occurrences, the relationship between BMI and omitting insulin to lose weight did not show statistical significance. So what are the implications on practice? The predictors, so genders identifying as a woman or being younger, at the age of diagnosis may be helpful to identify those who are at a higher risk of insulin emission to lose weight. And it points to the fact that the experience of having emitted insulin to lose weight at one point in life was associated with more detrimental health outcomes, so more microvascular complications, higher diabetes distress, detrimental lifestyle factors like weight cycling occurrences, and higher alcohol intake. And finally, that people with type 1 diabetes may be at risk of insulin emission to lose weight regardless of their BMI. Moving on to the next study, we looked at the factors that predict stigma perception in people with type 1 diabetes. And this project was guided by patient partners or individuals with lived experience of type 1 diabetes who contributed from inception to manuscript review and ensuring the research remained relevant to real-world challenges. So we looked into stigma because managing type 1 diabetes is visible, whether it's injecting insulin or wearing a pump or checking blood sugar. And when symptoms like tremors or loss of consciousness or seizures happen, they can draw unwanted attention. And unfortunately, these behaviors can be misunderstood and stigmatized, which can lead to blame, fear, or negative attitudes. So people with type 1 diabetes may face judgment, discrimination, or even prejudice because of their condition. So as a result, some choose to hide their diabetes to fit societal norms, which can make managing diabetes even more difficult. And the impact of stigma on health outcomes makes it clear that we need to find ways to reduce type 1 diabetes-related stigma. But to develop effective interventions, we first need to understand what drives stigma, what factors contribute to it, and how perception may vary by age and gender. If we consider that stigma can be intertwined with broader systems of oppression, then experiences can be different across life stages and social contexts. So these factors weren't well defined and were the gaps that this study aimed to address. So to explore stigma in type 1 diabetes, we used data from the Better Registry. Perceived stigma was measured with the 19-item Diabetes Stigma Assessment Scale, or the DSAS-1, and participants responded to each item on a 5-point scale, from strongly disagree to strongly agree. And their answers generated a total score ranging from 19 to 95, with higher scores indicating a greater perception of stigma. In addition to the total perceived stigma score, the 19 items on the questionnaire are divided into 3 subscales, and each measures a different aspect of diabetes-related stigma. So first, it looks at how people with type 1 diabetes may be treated differently. And examples of these items are, because I have type 1 diabetes, I have been excluded by others from certain social events, or I have been discriminated against in the workplace because I have type 1 diabetes. Others think I am unreliable because I have type 1 diabetes. The other form of stigma is blame and judgment. And examples of items are others make unfair assumptions about what I can and cannot do because of my type 1 diabetes. Others think I need insulin because I haven't looked after myself. Or because I have type 1 diabetes, some people judge me if I eat sugary food or drinks. And then the questionnaire addresses identity concerns. And these would be things like feeling worried about telling people I have type 1 diabetes in case they react negatively, or feeling self-conscious about all the tools I need to manage my type 1 diabetes, or even feeling embarrassed when I have to manage my type 1 diabetes in public. So having these subscales, we wanted to look beyond just the total perceived stigma score and explore which specific form of diabetes-related stigma was most common. So before we get into that, I want to briefly go over who was included in the study and describe our participants. So we had 709 people with type 1 diabetes, aged 14 years and older, who completed the questionnaire on stigma from the baseline questionnaires of the Better Registry. 95% are Caucasian, 65% identified as women. We had 1 participant identify as gender fluid. The majority were at least 1 visible diabetes management device, whether it was an insulin pump, 44% of the participants, or a CGM with to 81% of the participants. And they overall had a good glycemic management. 32% reported an HbA1c at 7% or below, and 41% had an HbA1c ranging from 7.1 to 8%. So we found that perceived stigma was higher in youth compared to other age groups, so adults and seniors, which can reflect the unique challenges of this age group, including psychological demands, physiological changes, societal pressures, which can increase exposure to negative stereotypes and discrimination. And we also found perceived stigma to be higher in women compared to men, which also aligns with broader research on gender and healthcare. Women may face additional challenges related to their gender-based discrimination, and that can further impact their mental health. In terms of the most common form of stigma perception, I want to take your guess. So I have another poll question for you. So the question is, what are youth reporting to feel most stigmatized about? Is it A, because I have type 1 diabetes, others judge me if I eat sugary food or drink? Or B, some people think I'm unreliable because I have type 1 diabetes? Or C, I feel embarrassed about what people might think if I need help with a hypo? So again, I'll leave you some time to record your answers. So I see 77% of you think because I have type 1 diabetes, others judge me if I eat sugary food and drink. And yeah, it's the item that recorded the most agreement. And this item belongs in the blame and judgment subscale. So this perception can be particularly salient for young people with type 1 diabetes, perhaps as they gain autonomy for their diabetes care and they learn how to manage their condition independently. And especially considering that this subscale also includes assumptions that they're not managing their diabetes well, or that their diagnosis is a result of lifestyle choices. So blame and judgment were the most common forms of stigma perception, and actually all 6 items reporting blame and judgment were significantly higher in youth compared to adults and seniors, and similarly for women compared to men. This was followed by identity concerns, where again, youth perceived it more significantly compared to other age groups. And differential treatment was the least perceived form of stigma, so being treated differently across age and gender groups. In fact, if we look at the mean Likert score, they're below 2, indicating an overall disagreement with the statements. So this suggests that it was not necessarily seen as a significant issue by any of the groups. This could be explained by the fact that being treated differently is often the most overt and explicit form of stigma. It involves discrimination, social exclusion, rejection in social and romantic settings. So as a result, people with type 1 diabetes might be more likely to recognize and respond to other more subtle forms of stigma, like blame and judgment or identity concerns. They may also have more resilient coping mechanisms to being treated differently. They may maybe have learned to distance themselves from situations that could trigger stigma or negative reactions. Or it could maybe be due to having strong social networks of supportive individuals who help buffer this overt form of stigma. And I wanted to give more tangible examples of what does perceived blame and judgment look like for people with type 1 diabetes. So of the 709 participants, more than half of them feel judged if they eat sugary foods or drinks. 39% receive unfair assumptions about what they can or cannot do because of their type 1 diabetes. 32% report having others think it's their fault that they have type 1 diabetes. 32% report having others think it's their fault if they have to take insulin. 31% report having others think that they're irresponsible when their diabetes management is not perfect. And 29% report having others think that they brought type 1 diabetes on themselves. This really shows that perceived stigma and with feelings of blame and judgment to be very common among people with type 1 diabetes, and further highlights the need for interventions to reduce stigma and its impact. Before I wrap up this paper, I want to share the psychosocial and behavioral factors that could predict higher levels of stigma perception. We found that perceived stigma was positively associated with factors like diabetes distress, hyperglycemia avoidance behaviors, fear of hypoglycemia, and also depression. And on the other hand, we found that perceived stigma was negatively associated with social support, meaning individuals with stronger social support systems tended to feel less stigma. And to briefly share results from a recent analysis of the Better data that analyzed the use of medical identification in people living with type 1 diabetes. And they found that less than half, so only 42% of people with type 1 diabetes wear medical identification, despite its potential to save lives. And when we looked at those who don't wear a medical ID, they scored higher on the identity concern subscales of the diabetes stigma assessment scale. In other words, stigma plays a role. And they were also more likely to express worry about disclosing their diabetes and to avoid telling others about their condition compared to those who do wear a medical ID. So this highlights how stigma can influence not just emotional well-being, but also safety-related decisions. These findings reinforce that type 1 diabetes-related stigma has real consequences impacting both well-being and health outcomes. Targeted interventions are needed, especially for groups facing greater stigma, such as youth and women. Addressing stigma requires an inclusive, intersectional approach, recognizing the various factors that shape lived experiences. Education and awareness campaigns and support systems are key. Support should also address stigma-related stressors like fear of hypoglycemia, depression, and diabetes distress. And future research should further explore how stigma varies across ethnicities and socioeconomic backgrounds to ensure that the interventions are inclusive.
So we'll now skip to another part of the Better project, which is the development of the online self-guided training platform that we call the Support. So it's a platform that we've co-created with patients, healthcare providers, and as well as a good team of web designers. We started its development in 2018, and over the years it's improved as we get comments and input from our different participants in this study. We did at first base it, well, it still is evidence-based. The content, not only the content, which is based on guidelines and best practices and consensus, but also its format. So how do we really have users be engaged and stay engaged on this web-based platform? All the content was peer-reviewed, and the picture is in French, but it's bilingual. And I'll let you know a bit later on who has access at the moment, because it's an ongoing research project. So just to talk a bit more about its development, at first we started, so it was made for computers. So it's a website that was designed for computers first. It later evolved to a mobile-first design, meaning now it's available, so it's more convenient on mobile, although it's a website that can be consulted from any internet-connected device. We have over 60 courses that we've divided in categories. So one can learn on the basic knowledge you need to manage the disease, but you can also go to more advanced knowledge. And when our reviewers, so the healthcare providers that were reviewing the content, were reading whatever we were sending to them. For instance, the nutrition chapters were read by dietitians. Well, these healthcare providers told us they wanted to know more and they wanted to read the other categories. And so we opened it to healthcare providers, as well as it can be useful to go out of maybe your normal scope of practice, and because we know type 1 diabetes is really impacts the whole global person. So it's good to have knowledge on the different areas needed to manage the disease. So we have different features. We have downloadable PDF fact sheets, which are quite popular with healthcare providers, that they sort of handouts. We have videos. So we have either it's narrated videos that are more like explaining the theory. This image here is for instance, the mode of action of insulins. But we also have a lot of testimonials. So we have individuals living with type 1 diabetes actually sharing the story, sort of to get this it's indirect peer support, sort of. So by being online, there's no formal interaction in between individuals, but by adding these testimonials, we're trying to have each other learn from others' experience. So I said they're not in contact, but we do have a discussion forum, so users can exchange on their life with diabetes in the discussion forum, which is moderated by our team. We've evaluated this study as part of a feasibility study. Sorry, we've evaluated the platform. So we gave access to the platform for a year to adults living with type 1 diabetes. We had over 200 participants, and the aim was to see if so their satisfaction, their appreciation of the platform, but also how it impacts their daily management. So we questioned them on their fear of hypoglycemia and on the frequency of hypoglycemia, because as we remember, that was the first priority identified by patients, the hypoglycemia. And so by navigating the platform for a month, they reported having fewer episodes of hypoglycemia in the last 3 days. And also less people had a high fear of hypoglycemia, and they reported having more confidence in preventing hypoglycemia, but also in managing their type 1 diabetes with globally. So, and with a subgroup, we did interviews to better understand how they use it and what really they like or not about the platform. And so their favorite features were the downloadable fact sheets, the news blogs. So every week we post a news blog just to have updated information and to have it being sorry, I'm thinking in French. I have to switch my language to English. Anyways, for it to be really active and engaging, and we also have videos that they can look at. So that was really appreciated. They appreciate the fact that it's accessible, so it's anywhere, anytime, basically. It's trustworthy, it's interactive, and they have a personalized navigating experience. At the moment, if you want to sign up, you either sign up as a youth from 14 to 24, an adult 25 and over, or a healthcare provider. And that enables us to give different content to these different subgroups. So since this was also an interest for healthcare providers, we did do a study with them as well. So we've included in our study professionals that were not working in specialized type 1 diabetes clinics, but that did see type 1 people with type 1 diabetes. And so often these providers would see mostly type 2 diabetes, but once in a while type 1, and it could be a challenge for them to stay up to date in the rapidly evolving technologies. And so they also had access to the platform for 3 months, for 12 months. And we noticed that after 3 months, they reported improving their confidence and their knowledge in type 1 diabetes, and this was sustained over the 12 months. They continued to use it, and they gave positive feedback with an overall sort of a grade of 80%. So that was their appreciation. And so now I'll pass it on to Asma. So we're adapting it for youth at the moment.
Yeah, exactly. So we wanted to open the platform to youth as well. And given that young individuals face different challenges that are unique to their age group, coping with peer pressure, managing mental health, seeking personal growth as they gain more autonomy in both their diabetes care and other areas of life, diabetes education and support for self-management should be tailored to meet their specific needs. And so that's what we did. We adapted support for youth, and it became Support T, and T stands for transition. It was a co-design process where we involved youth at every stage of developing the platform, starting from with individual interviews, using the adult support platform to guide our discussions and to develop a first prototype. And we also held focus groups with both youth and healthcare professionals to ensure that the developed prototype continued to meet their needs and preferences. And both the content and format and features were adapted and were continuously reviewed by healthcare professionals and patient partners. So to share briefly on key results from our discussions with youth in individual interviews, and the purpose of this first adaptation study was to understand the needs and the different factors that are influencing self-management in youth as they prepare for the transition to adult healthcare. And the findings were used to tailor both the content and features of support. So we categorize factors influencing type 1 diabetes self-management into either barriers or facilitators, and both were either external or internal. So examples of barriers included not being given the opportunity to self-manage diabetes, and transition in care is a learning process for parents too, as they learn to let go and give more autonomy to their child. Difficulty navigating healthcare and administrative tasks, experiences of stigma, having to justify diabetes to others, mental distress. And some facilitators that were discussed were having support from peers, from family and friends, from healthcare professionals as well, access to technology, diabetes literacy. And so we use these barriers and facilitators to think of what type of features or content would reduce these barriers and enable the facilitators. So overall, youth prioritize features that facilitate access to information and increase their sense of support. And the learning content should be reliable, it should be practical and novel. So the changes that were brought from support to Support T were that it was adapted to a mobile-first format. We decreased the number of subsections of the discussion forum and just opened up the conversations. We added a search engine for quick search directly to the information rather than learning modules. We added illustration and videos showcasing youth to increase a sense of support, but also relatability. We also created shareable links to the platform's content to allow information to be easily shared on social media or directly with friends and family. Specific topics on content that was highlighted and that were discussed was the relationship with the healthcare team, transition to adult care before and preparing for the transition, during the transition and after, medical coverage, lifestyle factors, and what was emphasized here is how to act in specific situations. So we're familiar with the guidelines, but the real question was, what do we do in practice when faced with challenging circumstances? So the goal was to align our educational content with the realities that people actually experience. How can I prepare for my transition to adult care? How should I organize my file transfer? What should I ask my doctor during my first meeting at adult care? What should I do if I want to change doctor, and things like that? So we took all of this and designed a prototype of Support T, and we led focus group discussions with 21 youth and 9 healthcare professionals to gather impressions on this prototype, which now, like I said, became mobile first and offered a direct search access for topics of interest. And these were the results that we had. So we were able to confirm and add some features. So now we kept the downloadable PDFs. We have weekly news to discover new topics, but we also kept the search bar for when users had specific questions that they wanted answers to, videos explaining various self-management processes, alongside testimonials from other youth sharing their experiences. And like Emily was saying, it might be more relatable and better received than written text. Discussion forum, shareable posts, and an individual progression tracker of the different topics that were included. The topics were organized into 10 categories, ranging from diabetes in general, hypo and hyperglycemia, mental health, transition to adult healthcare, finances, as well as other situations, which grouped what to do on sick days, or what to do in traveling, or drinking alcohol, or sexual health, etc.
So now we have this newer version. So we've not only opened it to youth transitioning to adult healthcare, but to all adults living with type 1 diabetes in Canada. And so we are doing an implementation trial at the moment. So our aim is to assess the effectiveness of the platform, but as well to understand the context of its implementation in healthcare. So on this slide, we talk about the Support T implementation trial, which is happening in 4 type 1 diabetes pediatric clinic in Quebec. So we're including youth between 14 and 16 years old, giving them access. So the intervention group has access to the support platform, and we're going to look at its impact on A1C, their self-efficacy, and their readiness to transition to adult healthcare. So we are going in the, I'm actually going in the clinics, training the healthcare providers on how to use the platform, how to use it in their care. And we are having group discussions and individual interviews about their impressions, how they intend to use it, the barriers they see. So it could be anything from having a bad internet connection. It could be as simple as that, as lacking time during their consultations. And so we're sort of gathering this data to see how to implement it in clinical setting. So we started this in the fall, and we're still recruiting in these 4 clinics. So we've just a global take-home message on the support platform. So it was really beneficial and important to implicate the users, the end users, so the patients and the healthcare providers since the beginning, to really develop a platform that would respond to their needs, and it increases our chances of them actually using it. All valued the fact that it was evidence-based, and we do see the different features we put in to keep their engagement happening. And the fact that it's peer-reviewed really makes it a solid resource. We're evaluating it. Is it going to have an impact on the A1C, on the self-efficacy? That's what we'll see. We're also evaluating diabetes distress, quality of life. We hope that the fact that we're giving access to diabetes self-management education and support that is anytime and not just restricted to the actual moment they see their healthcare provider, we're hoping that it will show positive outcomes. So we are having this, so I was talking about the Support T study, which is happening in 4 pediatric clinics. We also have a study happening in adult clinics here in Quebec, but we are also including all adults with type 1 diabetes in Canada as a different arm to see if there's a benefit to having the platform be presented and used as part of their care, or is them accessing it independently enough to have positive outcomes. So right now, the platform is accessible, as I was saying, to all adults with type 1 diabetes in Canada, and all healthcare professionals as well. The URL is type1support.ca. This is the QR code if you want to log in. As healthcare providers, you can create an account. Just start by confirming your eligibility. And it's tested as part of a research project, so you'll have a small questionnaire just before, but feel free to go and create an account. So as a conclusion, before we take your different questions, if there are any, mental health is a key aspect of living, obviously, and managing type 1 diabetes, and it must be integrated into research and clinical care. We really see how the ongoing collaboration between healthcare providers, researchers, and people with lived experience is really crucial, and we really see the impact on how it improves not only the research, but the results and its translation into practice. Patient collaboration ensures research aligns with real needs, and the fact that the training platform that we've developed is co-designed, we really think it will help with daily management and support. So thank you for your attention. Of course, there's a big team behind all these projects. I think this might not even be an updated slide. So thank you for listening, and we can take any question.
Thank you both for a really great, informative presentation. There's a lot of really rich, important information there. And I think us in Ontario, who I'm assuming most of our audience is from across the pediatric diabetes education programs here, a lot to learn and also to think about the work that we're engaging in terms of developing and now finally rolling out our own provincial pediatric diabetes registry within the Born information system. So this is really exciting to see, you know, what things that you're looking at with your data. I know a lot of really important findings around mental health, the transitions. These are all things I think everyone here is really interested in. So I know we don't have too much time, but if people do have questions, please raise your hand. Hopefully we can figure out to unmute you or write questions in using the Q&A function. And I'll just also remind everyone to complete the evaluation for today's webinar. So we put the link in the chat, but you'll also be getting an email reminding you about this, and also to let you know about our other webinars coming up in the next few months. We've already have 3 scheduled, so really looking forward to that. Some of those will focus on technology as well as more content around mental health. And I know, again, these are topics of interest across the Pediatric Diabetes Network. And then a final nudge from my colleagues at Born, again, talking about the Pediatric Diabetes Initiative that we have underway, that we have 3 pilot sites already submitting their patient visit and patient data to this registry, but we're going to be onboarding the rest of the programs across the province over the next year and a half or so. So to please reach out to Born about when your site would prefer to onboard. And again, if anyone has any questions or comments, feel free to raise your hand or please put them in the chat or Q&A. Oh, I see I think there's a question in the chat about what Born sites are currently contributing. And I think maybe this is meant to be what PDEPs in Ontario might be currently contributing to the Better registry. I think that if I'm interpreting that question. So I'm wondering if our presenters might be able to speak to, you know, who in Ontario is contributing data. And I understand it's more of you're reaching out to individual families and patients to contribute their data. So they might not be coming from a specific program or site, but I'll let you answer that.
It's a good question. So we've been doing in-person recruitment for the Better registry. We started in Montreal, and we have a center in Alberta also contributing. For the moment in Ontario, I believe it's only through social media. We do have different handouts. We're sending posters and handouts to different clinics. But it's not, there's no official site for the moment actually recruiting with someone on site.
And
we do
is
have
it,
people, sorry.
yeah, I just want to clarify in terms of the Better project, the better registry is at age 14 and up. That's the age cutoff there.
So if the person is 14 and older, they respond themselves to the questionnaires. But if they're 13 and under, we do have the parents complete the questionnaires. So anyone can join basically.
Okay, great. Any other questions or comments? Well, we have a few minutes here. All right, well, maybe some questions could come in after, and I think we will share your contact information with everyone who joined today, so we could forward those questions to you. But again, thank you so much for sharing all of your great data with us. And I look forward to seeing, you know, I think you listed how many publications already from the project, and I imagine there's going to be a lot more. So I look forward to seeing all of the findings from this study, and I think it'll be very informative for the work that we do in Ontario to think about what's happening in other provinces and across the country. So thank you so much, and I hope everyone has a good afternoon.
Thank you.
Thank you.
Thank you.